Right.
Welcome everybody to our 18th UCD COVID seminar series. My sincere apologies for the delay and thank you all for being patient and waiting. But I can assure you that the topic that we're going to be discussing today will be well worth the wait. It's lovely to see familiar faces and indeed names on the attendance list. And thank you for coming back again. Most of you know I'm Fiona McNicholas, child psychiatrist, and with my colleague, Dr. Bláthnaid Gavin, we are hosting the seminar series, which will now run into 2021. We're greatly facilitated by Paul Harkin at UCD and the College of Psychiatry, are co-hosting. Please feel free at the end to use the chat function or during the talk if you wish to ask questions of our speaker. I'm delighted, and I hope by now that Dr. Ellie Brown has had a chance to catch her breath and have a sip of water as we were trying to sort out the technological issues. So Ellie is a consulting psychologist who has many years of experience working in both the UK, Qatar, and in Australia, where she's currently working. She's a postdoctoral research fellow there. And I think her recent scoping review has attracted a lot of media attention and has led to some new research in that area. And that's going to be the topic of her talk today, looking at epidemics and pandemics and the effect it has on psychosis. Ellie, over to you, and thank you very much.
Thank you so much, Fiona, and sorry everyone for the technical difficulties. You'd think after having to use Zoom so much since March that I would be more competent at it now, but no. So I will begin swiftly and I will try to keep on pace, but also leave enough time for questions at the end. So I'm talking about a rapid review that we completed on the potential impact of COVID-19 on psychosis. So where did this come about? So this started back in March, I think it was about March 16th in Australia, which was when Orygen as an organisation was kind of a step ahead, thinking, oh, this isn't going right, we need to do something here, we need to ask everyone to be working from home, we need to shut down clinical trials, we need to be moving quickly on this. But what obviously couldn't move quickly was the clinicians that we work with in our research, in our clinical stream. They needed to still be on the ground, on the front line, as we say, working with the young people in the early psychosis services, which is EPIC. And obviously there was a lot of anxiety around for them. We were feeling that, and we were kind of thinking, well, what can we do as researchers to try and help them? Is there anything we can do? So we kind of brainstorming, and we thought, well, what do we know from the literature? Is there anything out there that could be telling us what's going to happen in the next weeks, months, years, as a result of the COVID-19 pandemic? We're aware that there's lots of discussion about the impact of COVID-19 on the mental health more broadly. So people already started to talk about the impact of isolation and lockdowns on depression, anxiety, and social well-being. But actually, we needed to know more about psychosis. So we were really wondering, were there any reports from previous pandemics around psychosis? Had anything already been published from COVID? And simply we didn't know. We had no idea what we were going to find out there. We wanted it to be quick. We needed to get some findings. We needed to get it out there. It was helped by the fact that we worked with colleagues in Canada as well, so we could do this kind of round-the-clock reviewing. And so this is the paper. And we began the 16th of March, and it was published on the 6th of May, which at times felt like quite a long time, and still does now, but actually it was really quick, and thanks to Schizophrenia Research for facilitating that. So some specific questions that we aimed to answer from our rapid review were, first of all, is there going to be a change in the instant case of psychosis or being identified at ultra high risk? We're starting wondering kind of, oh, is it the psychosocial triggers that are going to kind of push people from that that state of being being okay just about managing into an episode of psychosis. We also wondered about whether there's going to be any changes to the reports of the form and content of the psychotic symptoms. Was there going to be kind of incorporating the beliefs about the virus into the symptoms? That was something, again, that kind of the clinicians that were in the research group we worked with, they were kind of starting to think about and wonder about, and how they were best managed. Was there going to be a change in demand for inpatient and community-based services? Was there going to be a deterioration in the physical health of people with psychosis? We were kind of really aware that around the world everyone was being told to stay at home and exercising. We were fortunate in Australia that we could, that was very much prioritised, but we know that countries around the world were being told that they can't get out to exercise. We wondered if there's going to be an impact on the number of people with psychosis suiciding or attempting suicide. We also wondered what kind of functional impacts there were going to be, such as loneliness and other kind of relationships issues, unemployment, homelessness, and kind of holding in mind that this was all very much at the really early stages for everyone around the world, apart from in China. We also wondered how people with psychosis were going to experience the preventative measures being put in place. So the social, physical distancing, the increased hand washing, and then kind of all the other ones that came down the line. So in Australia, we have to wear masks. Oh, sorry, not Australia. In Victoria, when we leave the house, we have to be wearing a mask unless we've got a reason not to. And there's kind of quite heavy fines being handed out for people that don't. And then of course we went on to have we've got the contact tracing app, and then of course it's the staying away from others. Right, okay, so our review. Our inclusion criteria were primary research, including patients that had a psychotic disorder, and we included ultra high risk into that as well, have been exposed to an epidemic or pandemic, so we thought about SARS, MERS, H1N1, swine flu. We also included kind of early things on COVID. Needs to be in English and published in a peer-reviewed journal. And then we said that it was going to be published after the year 2000, which we took kind of just before the SARS outbreak. So that's kind of why in our title we're kind of reflecting the fact that it's contemporary evidence. Although in reality, kind of anything that we did find from the kind of from before that was really way back reflections on the Spanish influenza. So what did we not include? We excluded anything relating to the HIV or AIDS pandemic. We made this decision because it was deemed that the kind of mode of transmission was different. It's not an airborne transmission. And also that kind of the psychosis, schizophrenia, AIDS, HIV is already pretty well known and unlikely to be relevant to the COVID-19 pandemic. And again, it kind of really facilitated the rapidness of the review. We also excluded kind of any papers that referenced that were around the association between maternal influenza and adult schizophrenia. Again, kind of actually there'd been a very timely review that had been published by Robin Murray's group about around March. Okay, so in total we screened 3,000 papers, full text screen 35. Found that majority of them ended up having the wrong patient population. So for the most part, it wasn't a population of individuals with psychosis, and ended up including 14 studies. So the 14 studies that we did include were 2 on incident cases of psychosis. So patients that were not infected with the virus, and then 7 of those where it's reported the people that had been infected with the virus. 3 papers related to adherence with protective measures, 2 around risk perception, and then 2 on the impact of service use. Okay, so first up were the incident cases of psychosis in people that weren't infected with the virus. So both of these related to the COVID pandemic, and both kind of started to hint at actually was there something about this pandemic that was going to trigger off an increase in people presenting with psychosis. The second set of findings we had was the patients that were infected with the virus, so were infected with SARS, MERS, H1N1, or the kind of family of coronaviruses. So again, this is kind of hinting at and small incident rates, but still significant when you're considering the incident rates within a population, and particularly within the population of a virus that is spreading as rapidly as COVID has. So most of them were in SARS, and obviously from Hong Kong. Then one from MERS in South Korea, where it was kind of picking up those people that were the survivors of the MERS virus, but they were presenting with psychiatric symptoms, some of those which were related to hallucinations and psychosis. A couple of case studies, and then another paper that related to the kind of the actual coronavirus itself, so the presence of in their bodies, in their blood samples, suggesting that it might be a comorbid risk factor. So our next set of findings were around adherence with protective measures. These were, again, a couple were from the SARS outbreak, epidemic, and kind of suggesting that the symptomology would lead to non-compliance with infection control measures, and that the kind of need to get people to follow them was led to some people ending up in compulsory quarantine, which kind of seemed quite shocking at the time, but as kind of things have unfolded a bit, and what we've seen in Australia has with kind of lockdowns of public tower housing and stuff doesn't seem quite as shocking as it did when I remember reading it back in March. There's also a study that was related to swine flu that was undertaken in Australia, and that was a survey of adults with schizophrenia and then a control group without schizophrenia, which reported that people with schizophrenia stated that they were less likely to be willing to receive a vaccine, and they were more concerned about the adverse reactions from a vaccine, also less willing to be isolated. So the next set of our findings was risk perception in people with psychosis. So kind of thinking about what that meant for people's willingness to follow the infection control measures, but also that kind of their risk to themselves of catching COVID. So fewer inpatients were worried about the threat compared to the controls in the study from SARS in Israel. And then kind of something around, there were findings around how they related the epidemic as a message from God. And that wasn't something that was obviously picked up on by the staff. And kind of a similar finding in another paper from the study in Australia in the swine flu, which was that they felt that people with schizophrenia were less likely to contract swine flu. Finally, we looked at the impact on psychiatric services. So overall, there was only 2 studies and quite different settings. So one was in Sierra Leone and the Ebola epidemic, and that was kind of that spoke about the challenges associated with the difficulty, the challenging services that they had in the first place, but then also how that led to the hospital having to close to prevent the disease transmission, and how to manage that when you've got already very limited resources. The paper reported the creation of a new service that was that was in an outpatient service, and a very high rate of people that presented to that hadn't managed, that had kind of had their treatment stopped or hadn't been able to access treatment, hadn't been able to get medication, so kind of traditional and faith healing accessed. So, you know, a very different situation to what we were going to be experiencing in Australia, but important to hold in mind nonetheless, considering this is a global pandemic. The other paper by Pang was an evaluation of services used in Hong Kong. So in their paper, they saw a reduction in the use of psychiatric services following the outbreak, and kind of the challenges associated. Well, and obviously this was a time when we didn't have computers, and we didn't have the kind of the high quality telehealth measures that we've got now. So what did we conclude, and what have we experienced since then? So we concluded that our clinical implications were that we were going to be potentially more likely to see people present with psychosis as a result, possibly due to stress, or the actual viral, or the actual virus, or actually as a response of the treatment triggers. So a number of those papers that looked at the rate of psychosis in people that had experienced a virus, talked about how it was the steroid treatment, the high dose of steroid treatment, that were triggering those episodes of psychosis. And actually we've gone on here a number of a handful of papers that have already pointed to this increased presentation of people with psychosis, and since there's even a couple more already. Individuals with psychosis might be less likely to adhere to preventative measures, and in turn putting them more at risk of catching COVID. And that is something that had been picked up by the clinicians in our services pretty early on, and kind of how to work with, you know, having the need to work with our clients carefully, but also kind of put that at the forefront, kind of helping them understand, well, how do we get them to adhere to these measures? And as the measures have got tougher over our second lockdown, it's been even more important to help to support them to understand the importance of adhering. We also concluded that changes to the level of service use were going to be likely, and we tentatively suggested that there might be decreases in service use followed by the kind of pick up after that initial drop. However, there was a lot that we didn't find information for, and that we still kind of felt unknown. And that there wasn't anything about the form and content of psychotic symptoms. There's nothing about the impact of physical health, or on suicide, on homelessness or unemployment, and also no data on the impact on UHR individuals. Obviously, it's important to think about the limitations of our review. We tried to keep things super rapid. As a result of this, our search strategy was not peer reviewed. We only chose three very comprehensive, but 3 databases for search. So there could have been some other papers there that we missed. And data extraction was only completed by one individual, again to kind of keep the momentum going. So what next? So where we are in Orygen, we've had ethics and governance approved and this has started to survey the impact of COVID on the young people attending our services. So we're going to be surveying these individuals with psychiatry registrars that are going to be completing the interviews. They're the ones on the ground that do have access to all these individuals at the moment, and obviously there's kind of no funding associated with this piece of research, so it really is a case of doing what we can with what we've got at the moment. So we'll be collecting data from the demographic data, data from the mental well-being, so BPRS, PHQ-9, SOFAS, looking at their substance use as well, also their physical levels of physical activity, whether they're experiencing the kind of how lonely they're feeling. There is a novel fear of COVID scale that we'll be using, and then there's a handful of other novel measures that we will be that we've adapted from the papers we've seen in this in the studies mentioned in this review. And for some of these measures, so for the BPRS, the PHQ-9 and the SOFAS and substance use, we'll have for those that have been in the service, we'll have pre-pandemic measures that we can contrast these two. So we're going to be looking at what changes have we seen in service use. So we're going to be looking at referral rates to both the first episode psychosis service and the UHR services, and also the intensity of services required due to change in acuity. So that's we've already kind of been able to take a look at some of that data. I won't. It's not ready to be presented here yet, but there's certainly kind of there's certainly been a spike in the kind of amount of hours that each client has required input for over those kind of early. So there was a decrease, and then there was a real spike in the amount of hours, the intensity that people experience, the amount of care that was required. Another question that we're hoping we're going to be able to look at is, has there been an impact on duration of untreated psychosis as a result of the change in referral rates? So with that kind of drop of referral rates, as you know, all medical services have been experiencing around the world, kind of due to the pandemic. But for this population, this is really, you know, this is extra important, because this is increasing their if this is increasing their DUP, then kind of what does that suggest is going to be happening down the line? We're also going to look at the kind of model of service delivery. So we're still all completely, as much as possible, delivering treatment online. Obviously, when in clinical need, then it is face-to-face and home visits. But as much as possible, clinicians are still seeing the young people through telehealth, and groups are being run online, and exercise groups are being delivered online. So we're going to try and pick apart, well, actually, is that something that young people want? And perhaps most importantly, do they have access to adequate technology to support that, and can they use it, unlike me? Okay, so hopefully I've gone through that fairly rapidly as a rapid review, as our references, and would love a chance to take your questions or to hear your experiences. You don't know what's going on in a country until you it's very hard to understand what's going on in a different country until you kind of hear from those individuals. So if anyone's got any experiences to share in their work with young people with early psychosis, I'd love to hear them.
Thank you very much, Ellie, for your presentation. And goodness, that must be a route in terms of getting from the beginning of the paper to publication. So certainly well done on that. Very interesting.
There was also a knowing that schools were about to shut. So if we had to get anything done, we had to get it done before the schools shut. We had to go move to homeschooling as well as as working.
Right. One of the things, if you could just kind of maybe the papers that you found, there was quite a variation in terms of the risk of psychosis. I mean, the one in Hong Kong, you know, suggested 25% increase in psychosis post-SARS. Could you give us a kind of a general takeaway? I mean, thinking the baseline rate of psychosis is about 1% or so.
Yeah.
How much of an increase from any reason do you think there was from the other pandemics that you looked at that would allow us maybe to think about COVID in that light?
Yeah, I think we quoted that as kind of there was a increase of kind of 1 to 4% were the ones that we should kind of really be considering. The one for 25% was was a paper out of China from the early kind of COVID. So maybe like January, I think. And they looked at referral rates compared to that time last year for them, and that was when they saw the 25% increase in people presenting with a episode of psychosis, and also that the kind of mean age of the people that were presenting were in their 50s, so it kind of really shifted from that younger cohort to being older people that were presenting. So, I mean,
and for that particular group, because I mean, you know, that's an alarming increase. Was that, and you said that was not in COVID infected individuals, they were COVID negative.
So those ones were, yeah, I imagine it must be, because it was a large kind of population sample. It wasn't in Wuhan, so it was the kind of population outside of where people were contracting the virus at the time. I'd love to, yeah, it would be great to go back and revisit those numbers. There hasn't been anything else out from China. It's kind of more of the stuff. The symptomology has been picked up in the studies in Europe and the UK at the moment. There hasn't actually been anything else come out. So I'd love to be able to give a number, but I don't think, you know, the quality of the papers was low, and I think it will be very important for us to drill down into the data that we have in Orygen, and anyone, you know, any other services that has access to that data, and really try and get a sense of what it is. And I guess with all pandemics, we don't know until afterwards what, you know,
yes. The sense both from the published literature and anecdotally from our own teams here is that referral rates had significantly dropped immediately post-COVID. And it's not clear yet whether they've actually reached the pre-COVID levels, you know, not just in psychiatry, but in, you know, many other specialties as well.
Yeah.
Is that what you're finding in Oregon, that the referrals had dropped or slowly coming back up?
They massively dropped, and then they really have kind of taken a steep rise, and there's a huge amount of need at the moment for, and possibly related to the fact that we're in the, you know, we've been in our second lockdown for a couple of months now, but a huge amount of need for inpatient services, people presenting kind of, and then kind of really complicated by the fact that people leaving, you know, it's very, it can be difficult to get people out of the services into another place because of the restrictions on movement and the kind of lockdown orders we have. But yeah, you're right, like that kind of, we're probably going to get this happen, and kind of what's going to, you know, what implications does that bit have when referrals that would normally go and access treatment or would somehow find their way to a GP can't go to a GP because they're not being seen face to face. What's happening there?
And if the normal pathways to getting assessment, you know, fewer GP referrals, fewer referrals into psychiatry, do you think that both the severity of the psychosis and maybe more likely to be picked up, you know, in public places and brought in under the Mental Health Act, do you think that that is going to be a possibility?
Yes, and I think kind of some of those papers are, some of the papers that have been published in the last couple of months are speaking to that, and kind of it is only case studies at the moment. We've got to remember how slow the research process is, and that these are probably busy clinicians that are writing up these case studies. But yes, they're in A&E, so that they've ended up they've accessed treatment through A&E rather than that kind of typical, perhaps primary care pathway. So certainly there is, so people kind of ending up in A&E, so the ED, so the emergency departments, accessing the care that way, so that kind of, or like you said, the kind of, there's been case studies of people being picked up for a public nuisance, I guess I think is the term that's been used in several studies.
And one of our participants, in fact, who works in early intervention services, has stated that they've seen about a 20 to 30% increase in first episodes, and also in the older age group, a little bit like you were saying in the Chinese data that you mentioned. Yeah. some of whom have COVID but mild symptoms. Do feel free, Marianne, if you'd like to, speak to that a little bit more. Because I was going to also ask you, Ellie, what percentage of cases do you think actually, there's the suggestion that COVID is kind of, neurogenic. It likes to get into the central nervous system. But having said that, really there's very few case reports or data on psychiatric illness. What percent did you find in the papers by way of psychosis from infection as opposed to secondary treatment, let's say with steroids?
Yeah, that was kind of the, I think it would be really hard. There's so little to pick apart and kind of pick a number from. I think if I go back, let's have a look at, it'll be on this slide with the incidents. So there's kind of this paper here by Sheng in the SARS population. So 100 people that had experienced SARS, and 4% of those were presenting with auditory, visual, or persecutory ideas, kind of in that acute stage of SARS. So that was, but again, it kind of, no one was able to really pick apart, well, is it the treatment or is it the experience of the virus? Is it the virus causing it, or is it the fact that the treatment that they had to have as a result of the virus? And I think there's work being done out of California by some colleagues that are trying to pick that apart a bit more and kind of really understand the viral implications and that. And I guess it's probably, I don't want to speak to it too much because it is outside of my remit. Kind of thinking more on the service level and how we work with people on the service level, but it's complicated. It is so complicated, isn't it? And that we really don't know, and we're seeing these case studies, novel case studies coming up every day.
In terms of the slightly higher instance in younger people that one of our members mentioned, and thinking about, there's also been literature on the increase in substance use in this population during COVID. What effect do you think, or are you seeing an effect from cannabis? Is there proportionally more cannabis-induced psychosis, or do you think there will be, or?
It's a great question, and will be one that we'll be able to answer. And we're also going to be we're looking. We can do that from the clinic notes, and we can look at what they were answering from the substance use scale, and see what they've been using more recently, and kind of compare that to behind. I guess for some other work that we've done, kind of pre-COVID, was actually in Australia, we've got a really big issue. Our population is a really big issue with methamphetamine use. So kind of almost similar rate of usage with methamphetamine as to cannabis. So yeah, I would love to come back and present that data when we have it. Kind of, it does go back to the slow process of trying to do research during a pandemic, during trying to homeschool, and with limited funding. But we've got a rich amount of data in our department, so hopefully by the end of the series, if you said you're going into next year, then we can come back and present that data, because I think you're right. It's really important that we start to understand this and not just kind of leave it on that. These are the case studies. We need to look at it in more depth and have some actual data from it.
There's also some interesting data coming out on COVID in terms of who are at risk of being infected and adverse outcomes. The individuals with obesity, they're linking it with low vitamin D levels, and indeed interventions offering vitamin D seems to be very, very helpful. But interestingly, they found with antipsychotics, it lowers the rate of vitamin D also. And I'm wondering, in your study that you're proposing to do, or indeed in cases that you've come across in your reading, how many of them have been on antipsychotic medication? And is there any suggestion that, we should actually, from a clinical perspective, especially in Ireland, you're better off in Australia with your sunshine, but vitamin D levels in Ireland are very, very low, and they're going to become lower now. you know, we've had a nice week, but that won't be enough. And we certainly aren't eating enough.
Yeah.
Do you think we should be, I don't know if you've read about that, or should we be adding vitamin D to our population, our clinic population, as part of, you know, treatment, and paying attention to their food intake as well, which is another risk factor for this cohort?
Yeah. It's a very good question. I would love to say that we could look at it. I certainly think we'll be able to look at kind of at their what they're being prescribed and their medication. I think there's also some work that James McCabe's done from the Maudsley, looking at the impact that that being on clozapine has had.
Been on which?
For being on, if they're on a clozapine.
Right.
So and that kind of, that has raised the risk. But then again, it's kind of, it's always down to the small numbers that we have in our population anyway, and you know, they had a relatively reasonable exposure of patients that had COVID, but it was still kind of like, you know, it's 100 or something. So it's small numbers that we're working with, and probably we need to be thinking about how we can work together globally to kind of answer some of these research questions and get the numbers that we need to understand this and then better support our clinical treatment. I wouldn't like to say, you know, kind of vitamin D or not. I guess there's never going to be there's never going to be an answer to address these complex presentations at the best of times, but even more so now. But I guess getting outside and exercising is we know that's good, but yeah, remembering that.
One of the participants have also said they've seen a 31% increase in caseloads across the south of England. I'd be very interested to learn whether that was, obviously, is it in psychosis or is it in all groups referred? And does this suggest that things are beginning to go back up again? Because my understanding from some of the UK data was that, you know, they hadn't yet gone back upwards pre-COVID levels. So do feel free, Sarah, if you'd like to, you know, speak to that, or if you'd like to send a chat message. Ellie, I was also interested in your idea and a discussion around the behavioural management of some of these individuals who, you know, psychosis is one reason why they find it hard to adhere to the restrictions that are in place, but the same apply for individuals with learning difficulties or autism. You know, what are the ethics around putting somebody in quarantine because they find it hard to adhere to the wearing of masks, when we're allowing other people who have breathing difficulties not wear masks for similar reasons?
Yeah, I don't have an answer, but you're right. Like it's so hard. Like, you're just trying to battle on so many levels, and then, you know, so much societal and political pressure that are playing into that as well, without understanding the context of what we're having to work with, and the beliefs that we're having to work with, and kind of some of those reports that you've seen around rape victims who kind of, you know, really that the trigger, it's a triggering factor to have a mask over your face, because that was kind of triggering memories of being suffocated, and what you can kind of, you know, what we should be expecting in that situation. And then of course, you know, here people, you know, we have had a number of young people using our services who have received fines for not wearing masks, or kind of being challenged, you know, if they're being challenged by the police, kind of how that's being handled by the police might perhaps not be as well received as it could have been. So yeah, I mean, it's so complicated, and there isn't an answer, and we're constantly firefighting at the moment. And you'd think we'd know. I think we've been in this since March is quite something, really. So 6 months.
And in your current clinical practice and the wards at the moment, you know, just like in some of those studies you mentioned, where they're automatically quarantined individuals, and these are individuals, I imagine, who are not infected with COVID. Is that correct?
Yeah. Yeah, so we had a situation whereby the ward, someone tested, but a staff member tested positive in the young person ward. So it's 18 to 25. And of course, kind of what came from that was that everyone had to be locked down into their rooms to try and to prevent any further transmission. Home visits were cancelled. Smoking was going out, being allowed out to smoke wasn't allowed. So that was a really challenging time for the young people, but also the clinicians as well, and also being aware that their colleagues someone had contracted it and they were pretty unwell from it. But of course, as clinicians, we were kind of trying to think, well, what things can we do? How can we use computers, use the internet, use the access that we've got? So can we kind of do group movie nights, and also kind of maintaining those group-based interventions through the networks that they had. But yeah, really hard.
And I guess it's very important we make sure that in our effort to protect, that we don't inadvertently stigmatize, certain individuals, and that there's parity between, those for hypersensitivity reasons can't wear masks, and everybody accepts that that's okay, but yet somebody, who either by virtue of their psychosis or learning issues, it's important to think about that. It will be a challenge. Just getting close to our finishing time, Ellie, there's one of our speakers, or our audience has asked, given the neurotropic nature and indeed the brain inflammation associated with COVID, have there been any studies following babies? Obviously not, you don't mean in COVID, it's too soon, but from a previous pandemic, have there been any studies following babies in utero who may have been exposed, I guess, either, mothers having infections themselves, passing it on to their infants?
Yeah. So that's the kind of area that we did exclude. So we did it because there is already quite a lot out there on the kind of the flu, that relation to maternal influenza and going on to develop psychosis in young adulthood. So yes, there is a lot out there, and you're right, absolutely, that should be something that needs to be held in mind in future generations, which is scary. It's kind of it's another reminder of just how long lasting the impact of this pandemic is going to be on the global population.
I think what's there at the moment with COVID is that there hasn't been any maternal to infant spread. And I'm not sure that even in breast milk they feel it's a risk. Although I did read something about breastfeeding mothers having to mask up, and I wonder about, the issues with that with the little baby, and but both in terms of the reciprocal nature of the bonding between the mother and the child and the anxiety around all of that. So it is a very, I suppose it's a very difficult area, but one that maybe has to be followed. Do you think from the SARS that there has been significant psychopathology in the offspring?
I honestly can't remember, because we definitely worked to exclude that. I don't remember seeing anything that came from SARS though, although I can imagine it's 10 years, 15 years since the pandemic there. So maybe it would be something that would kind of be starting to be associated now, and kind of, it might be something that they'd be seeing in their referral rates in early psychosis now. That kind of that would be the age gap now. So I guess it's that holding in mind just how long lasting that is from the time of pandemic. Yeah, I mean, given how little there is anyway in the area, and this kind of consideration, I doubt there would be anything, but it would be a very interesting research question to answer from data from Hong Kong.
I mean, I guess what we're faced at the moment is, Dublin is, now at another stage of alert where the virus is spreading significantly, and where everybody has, once again being asked to restrict their movement. I guess you have two groups of people. You have one group who are saying, well, look, for the vast majority, they don't get badly affected by it. Their clinical outcome is reasonably good. Many of them don't even need any specific medical intervention. And, you know, you've got the other group that are much more at risk and indeed at risk of dying from it. But increasingly, there's also a concern that we don't know enough, that there's long-term sequelae, even when individuals have more or less meant to have recovered from it, even if their clinical course had been quite benign, that they end up with a lot of cognitive difficulties and indeed mental health difficulties akin to kind of chronic fatigue. So it seems like we can't be too complacent about it. And
no, and I've seen some of those kind of the neuro sequelae are being an increase in dementia as well. So I read something the other week about that kind of almost something about kind of triggering that those cognitive difficulties into, you know, in the older population, of course, but you know, if you're kind of, you know, if you're going to be at risk, and then that's going to then you're going to contract the virus, and that's going to lead to dementia, symptoms of dementia being triggered. That's another population that we need to hold in mind.
But I think
the problems they're experiencing, but also being at more risk of the cognitive decline.
I think the research you're embarking on, Ellie, is going to be very exciting, and we look forward not only to your research, but indeed to the cumulative experiences of all the clinicians here, you know, who are seeing, as they have suggested, increasing numbers, the possibility of increasing psychosis being blended into other mental health difficulties.
Yeah.
I'm very aware that you know, everybody is probably anxiously finishing up stuff without knowing what the outcome of this evening's NEFIT and government decisions are. Oh, and I've just got a cramp in my leg. So
but
I'm going to...
got some important, some government stuff going on today, have you?
Decisions will be made whether Dublin, at what level of restrictions the county and city of Dublin should be at. So yeah, unfortunately, there will be more restrictions. Yeah. But Ellie, I'd like to thank you very much for giving the presentation and for food for thought. And we look forward to your study as it emerges. And thank you very much. I'd like to thank all the audience for bearing with us with the initial delay and for staying through the presentation. So I hope you've enjoyed it. I would just like Paul to let everybody know the next, I'm going to close that. The next webinar is going to be from Dr. Peter Rice, and that's going to be on alcohol self-management during COVID. And I think that we're aware this is going to be an issue, and it's the appropriate use of alcohol and the risk now if pubs are going to be closed, I guess. You know, that's going to create additional problems. And lastly, just to remind you that on the 16th of October, we will be having our conference in UCD on occupational stress and burnout among healthcare workers. So thank you all very much. Have a good weekend, and looking forward to seeing you again next week. All the best.
Thank you.